Welcome to JACC This Week, where impactful science meets global insights. I'm Dr. Carolyn Lam, and I'm here with Dr. Harlan Krumholz as we go beyond just summaries and discuss why findings matter, what was debated, and how the field should be thinking differently. Thanks again, Harlan, for being here with me. Really excited about this week's issue.
It's always a pleasure, Carolyn.
So it's a mini spotlight issue on adult congenital heart disease. Harlan, what is this, a mini spotlight?
Well, mini spotlight, we're always curating content and trying to put it together in issues in ways that readers will appreciate. And this week we had the guidelines drop from the Adult Congenital Heart Disease. And what we did was we brought together some experts in that field to comment on those guidelines. And we put together a commentary and the guidelines into a nice little package. And so we call it a mini spotlight on the ACHD guidelines.
That's so cool because also having adult congenital heart disease, right, ACHD, as that spotlight, I really appreciated how you framed it in your editor's page. Just sort of pointing out this is not just a subspecialty. It's an exemplar of a broader transformation occurring across cardiology where our advances have turned conditions that were once uniformly fatal or rapidly progressive and into chronic diseases that are characterized by long survivorship and a dependence on deep expertise in chronic management. So we think immediately, of course, adult congenital heart disease, but then cardiac amyloidosis, like we've discussed before, and perhaps other diseases that may be coming up in new issues. Hint, hint. That's what you said, right? In the editor's page, Harlan. You want to tell us a little bit more about that concept?
Sure. Thanks, Carolyn. And I think you captured it pretty well. Look, in these editor's pages, I try not just to rehash what's already in the issue. I try not to just tell people what they're going to read ahead, but to get people thinking in different ways. And in this editor's page, which I titled From Survival to Stewardship, Delivering Hyper-Specialized Cardiovascular Care at Scale, I tried to explain both why this mini issue matters about adult congenital heart disease, but also to try to generalize it. So I start by saying congenital heart disease may be one of medicine's greatest success stories. We learned how to save children's lives. But that success created responsibility. We now care for a large and growing population of adults who survive complex disease and complex interventions. And many of those occurred maybe decades ago. And many look well, many feel well, and yet many carry lifelong vulnerability. And this shift we need to make is conceptual. For years, the implicit goal was survival, get these kids through this very difficult period. But now the goal must be, in addition to survival, stewardship. And that means anticipating problems before they declare themselves. It means recognizing that arrhythmias, heart failure, sudden cardiac death, non-cardiac organ dysfunction, mental health are not late surprises. They're expected risks that demand structured follow-up. And it means thinking at scale that there are not enough adult congenital heart disease specialists to care for every patient in isolation. So the challenge is not just clinical excellence, but systems design. How do we extend expertise through networks, shared care, digital tools, guidelines, as example, what's in the issue, so patients receive the right care at the right time in the right place. And so this issue exists to make the challenge visible and to begin answering it. I think what it also was meant to say is that we can learn from this field because it really is about how we think about hyper-specialized cardiovascular care. So we are now getting better at treating hypertrophic cardiomyopathy, amyloid heart disease, pulmonary hypertension, a whole range of really kind of specialized conditions, very narrow conditions that for a long time were really not associated with very good survival. And we didn't have to look at the horizon of long term, I guess, analogous to HIV as well. You know, what happened in the HIV community where it became a chronic disease. These conditions are becoming chronic conditions, and yet they really need deep expertise. And so this is our challenge, is how do we do like what they're doing in adult congenital heart disease? How do we know that we don't have enough people with deep expertise, but so we've got to spread that expertise through systems design and think about delivering hyper-specialized cardiovascular care at scale. So that's what I was challenging us as a profession to think about.
I love that so much. And it really explains as well some of the prior issues that we've had and hinting at some of the future issues we're going to look at. That's just so exciting. And it's just really important. You mentioned the guidelines that came out. You're right. We've made such big strides, and it's so important that we have updated guidelines, but also the perspectives surrounding those guidelines. So first, let's talk about the guidelines a little bit. So the 2025 guidelines actually update from 2018. So 7 years of progress.
Yeah, it's a long time.
Yeah. And what I really love, everybody, you have to get your hands on the issue because it really goes into and facilitates the entry into some areas of both science and clinical knowledge, what's known, what's not known, and the figures and tables provide convenient touch points that help to make a big document feel less imposing, and it's just really broadly clinically applicable to our leadership. For example, there's a figure that shows the closure considerations for VSDs. Of course, we all need to know that. It's all there in one figure. And then in another table, there's a table that beautifully summarizes the definition of right ventricular outflow tract dysfunction and offers this easy to follow synthesis of all the imaging parameters that are commonly obtained, and then how do you put it all together. So I really love that. But then in JACC, we've also surrounded these guidelines with lots of perspectives. So Harlan, which one stood out to you?
Well, let me just, thanks. I really think you captured it well. Let me just linger for a second on these guidelines, because I do think that they're a major contribution. And I don't know if you're like me, you were trained a little bit in congenital heart disease, and adult congenital heart disease wasn't really a big thing. And, the field's been moving quickly, and it's really incumbent upon us to track this, because there are now many people out there who have these conditions, and we ought to know about it. And, at the core of this guideline reframes adult congenital heart disease care as lifelong, dynamic, and risk-based, not static and episodic. And, a few features stood out to me of the guidelines themselves. They fully operationalize the anatomic physiologic classification, recognizing that anatomy alone doesn't determine risk. Two patients with the same lesion can have very different trajectories, depending on physiology, prior interventions, arrhythmias, ventricular function, so forth. Second, it strongly emphasizes the care within the ACHD centers are important, that people have touch points with people with deep expertise, and there needs to be close collaboration. This isn't about exclusivity, it's about matching complexity to expertise and making sure that there's that connectivity within the care. And then it places new weight on long-term surveillance, including rhythm monitoring, imaging, heart failure assessment, pregnancy counseling, screening for non-cardiac complications. And then, it does pivot to saying what the evidence gaps were. So I thought that the guidelines themselves, as you're suggesting, really worthy of a look. It both can update you on what's going on in the field, but help you understand how it's pivoting to kind of a new perspective, a new way of thinking about things. And then on these commentaries, we got a surgeon's perspective about timing matters, timing of operations, what should you be doing? We got a perspective on early career, how people who are entering this field are thinking about it, global and low resource perspective. Not every country has access to the kind of specialists that we might have, for example, in the United States. How is that being managed? And health system perspectives and more. And so, what we really try to do now with the guidelines is to provide a little color around them, to bring in people who are looking at it from different perspectives, so that you can get the guidelines, but then you're also getting kind of different, more nuanced perspectives, what they mean, what the future is going to hold, how people are coming at this, how the field's evolving. And we're doing this with greater frequency. But I think that I'm so proud of this. I want to highlight Anne-Marie Valente, who from Boston Children's, one of our associate editors, who just did a terrific job helping to curate these commentaries around it. And Erica Spatz working with her. It's really, in the end, I think it's a really nice collection.
I couldn't agree more. And Harlan, in our last few minutes, I'd like to just ask you if a reader is out there going, wow, that is cool. How do I make my particular topic or review or guideline or whatever. I think it's deserving to be a mini spotlight too. How would they, I see that smile. How would they go about that?
Well, no, I mean, we're doing this with all the guidelines now. And, we've done this with ACS guideline. We've done this with hypertension. This one was a little more specialized. So it became sort of a mini focus as we brought around it. But we're doing this regularly now, working closely with the guideline group. And I just want to highlight too, so there's mini spotlight. So there's also some other cool stuff in this issue. I mean, we talk about cardiac screening in the young and thinking about how we prevent cardiac death in an analysis of more than 100,000 individuals. There's a piece from the Confidence randomized trial examining the risk of hyperkalemia with patients treated with EMPA or finerenone or the combination. We have a piece about timing of benefit in finerenone. So, the issue is packed. It's packed with a lot of good stuff. And there's more. There's even more, including something on wildfires in LA and what was the impact on emergency room visits for myocardial infarction and other illnesses, not just pulmonary disease. So actually, it's a pretty packed issue.
It is. And thank you for mentioning the finerenone paper. I do also believe that the cardiovascular and kidney worlds are really coming together. And I think that there's just going to be a lot more of these cross-disciplinary looks at the cardiometabolic whole spectrum. Again, what a beautiful.
Well, we're lucky. I'm lucky enough to be on this podcast with someone who's really expert, of course, in heart failure care in general, but also these new trials. Were you surprised to find from Confidence trial that, the hyperkalemia was occurring more often, but most of the events were mild and manageable? And I think the central message from that paper, which I really liked, was don't be afraid of it. I mean, you want to monitor for it. We have to mitigate it, but it shouldn't get you to steer away from medications that might, have a hyperkalemia side effect. You need to be aware of it, but in general, people tolerate, and you just need to be vigilant about following it and then, preempting it before it gets to be a bigger problem. But I don't know if that surprised you at all.
Oh, Harlan, no, it didn't, but I'm just grateful to hear it coming from you because, I'm so close to the topic. I really like to be careful not to I'm sure you understand, not to make this podcast just about talking about the papers that I'm involved in. But yes, I totally agree. It's a needle that it's really hard to thread. I recognize what we all struggle with in clinics. We're so indoctrinated with the do no harm that sometimes we forget about, if I may, the sin of omission.
That's right.
And just focus too much on the sin of potential, if I may, sin of commission, right, when it comes to harmful effects. So thank you very much for also including papers like that. And I really hope the audience is now already having picked up the issue. It has been such a pleasure talking to you about this today, and I'm glad you've been listening to JACC This Week. It's bringing impactful science with global insights. Please, if you liked what you heard, subscribe, share, and email us. And see you again next week.